So the second assumption that we looked at was the use of triage 4-5 conditions as a measure of appropriateness. And we've already heard that the triage scale is a measure of urgency and not complexity, and that the lack of agreed definition and that there's a lack of an agreed definition of what is a primary care type presentation or not. In testing this assumption, we looked at some of those myths and perceptions within the literature that propose that the one-stop shop and the free service emergency departments provide are significant influencing factors in health-seeking behaviours of our residents at the study hospitals and at specialist hospitals. The literature does, however, unanimously agree that where a patient believes their condition to be too severe or complex for a general practitioner, they will present to emergency. To test the one-stop shop assumption, we looked at procedures provided to our residents with a triage 4-5 condition. We found that 61.8% of patient records in the 2010-2011 reporting period in the VMD were blank. So while that presents a significant limitation of our study, we did find that only 5.1% of residents had a record that stated no procedure performed. While the number of blank fields is concerning, the data does show, where available, that only a small percentage of residents accessed imaging services or received diagnostic tests of some sort. We found that at the study hospitals, residents were less likely to be administered drugs than those that presented at specialist hospitals. What we also found was that where imaging is performed for our residents presenting with a triage 4-5 condition, it is statistically more likely to be performed after hours, and it's twice as likely to be performed for residents that present with an injury. The literature often comments that where there's a cost associated with accessing primary care, especially after hours, and for patients that live in low socioeconomic areas, they are more likely to present to emergency. However, as Norman highlighted earlier, there's no people from low socioeconomic areas also are high users of general practice as well. To test the assumption around the role of cost, we looked at resident presentation rates by SLAs and their associated CFA rating. What we found was that residents from medium to high socioeconomic areas or the more advantaged areas were more likely to present to emergency with triage 4-5 conditions. However, there was no significant difference between patient socioeconomic status after hours. When we mapped where our residents chose to travel when presenting with a triage 4-5 condition, we found that our residents were more likely to present with a triage 4-5 condition at specialist hospitals. So we mentioned 59% before at the Royal Children's. What we found was that for our residents, and the specialist hospitals are mainly made up of presentations to the Royal Children's, 78% were actually triage 4-5 compared to 46% at our study hospitals. However, when we looked at after hours, our residents were more likely to present to our study hospitals than to the specialist hospitals. Yes. Yep, so the recommendations for this assumption is that we do need a definition of what primary care type presentations are, and that this definition is adopted nationally so that we can determine appropriateness. We need to advocate for the release of data sets at a minimum level of local government area, though preferably SLA, and we'll actually present to you some postcode data in the next assumption. And that the formation of a primary care data set is created and it's actually updated annually, and that we collect and report more on qualitative data regarding patient and sector experiences.
So the bottom line here is you don't know whether these people are appropriate or not.
No.
From that. Beggars, you spent a fair bit of time trying to come to this task of appropriateness and definitions. What results are you getting from your efforts?
Certainly on the issue of the definition, we recently, to show our complexities, we were recently invited to Canberra for a one-day, an entire day for an audience of people from government, ED, general practice, and there was no conclusion about the definition at the end of 12 hours of discussion. So, which is important. I think one of the things that is happening from July the 1st is activity-based funding, which, as that delivers sort of national data on what the activities are in the emergency departments, that may be able to, I suppose, start to explain this area a little bit more, but it is going to be a long time.
So the philosopher Wittgenstein said, if there is no answer, there is no question.
I think we are dealing with a little bit of evidence here and a little bit of opinion, so I think we have to go with what we've got to some extent.
So is the issue, as some of the speakers in the audience have suggested and some panels have implied, what's the problem? What's the problem that we're actually trying to solve? If people are going in and you are absolutely, the ED college is absolutely entrenched in the view that these are not GP presentations, we admit 20% of them. And if you're right in your admission and you're not just overreacting in the ED, which is a question all on its own, the question is, are people making self-selecting, making the right decision, or consumers actually far more knowledgeable than the person we give credit for, and we should just let the system work with it?
I think consumers are clever, and I think they often go to where, I suppose, they see less wait or a quicker service. I do believe that 4s and 5s is a very simplistic approach to defining primary care as ED, but in my experience there is still a significant portion of ED presentations which is indicative of failing the system, and then to me that reflects more that there isn't a system that delivers integrated disease management, and so there are many patients who are inappropriate in the ED, but there are no other solutions for them, or it's a failure of their chronic disease management, and they can be category 1 to 5, but it's not as simplistic as 4s and 5s.
Well, that's an issue I want to get on actually at the end of the day, because this is a study of 4s and 5s. But again, talking to people in the ED departments, their problem has never been 4s and 5s. Their problem is the person with chronic complex illness that doesn't fit into a triage category who blocks a bed for 5 hours.
Absolutely. Yeah.
Gareth, this issue of definition, appropriateness, what's a GP patient versus an appropriate ED patient?
Well, I certainly wouldn't be fussed about the 4s. There's enough ambiguity about whether they're appropriate or not. But I think certainly the NHS experience was that the 5s, which are much more likely to be primary care type patients, were incentivized to go to ED because they often couldn't get an appointment within 2 days with a general practice. So I think having a 4-hour that includes 5s is crazy incentives. So the 4-hour target should exclude 5s, I think. Well, I mean, yeah, I mean, there should be targets in general practice for that too. But in other words, this is about sharing the issue across both primary care and secondary care.
That's an interesting point, which I quite like your views on. Should part of your accreditation be, or even an added incentive, should actually look after particularly category 5s more in your practice? Should that be, should you actually have your practice manipulated by incentives and facilitators to move in that direction? Yes.
My name is Simon Jenkins. I think there is a problem with trying to provide a definition, because we're trying to provide a definition retrospectively after the diagnosis has been made. So if you go back to the reason the person goes to the emergency department in the first place with their febrile child at 9 o'clock in the evening, the parent's perception is that it's an emergency, they don't know where to go to, their decision at that point in time is that they're going to get the level of care that they need at the nearest emergency department. So, but then they go there and say, well, it's just a viral and she didn't need anything done, so therefore it's an inappropriate presentation. So I think, in some ways, by trying to define what an inappropriate presentation is not actually going to help us not solve the problem. I think that's about, going back to what somebody said before, about educating the community and providing alternative resources that they can access when they need them. And the problem is, with this group of patients, when they need them, they're not really available.
We're going to bust that myth in a moment, because that's a myth too. Because as you're about to find out, the people who actually go to EDs have plenty of general practices around. There's no shortage of availability. And the people who go to GPs. So this myth that we're spending a bit of time on at the moment is a myth, according to the data we've got here. Mary?
I just wonder whether one of the myths is that it's either or anyway, and that we live in a much more ambiguous world, and that if you consider any specialism in the hospitals, we have no hesitation in knowing that we're not referring to an orthopaedic surgeon, we're referring to a knee specialist. But people don't think about general practice in the same way. But there are GPs whose interest is far more in preventative health, and there are GPs who's far more interested in procedural medicine or far more interested in paediatrics. So there are a multitude of reasons why people go to where they go to, but also I wonder if rather than sort of saying they should be seen here or they should be seen there, we should be working at the efficiencies of that interface and making those systems flow better. So certainly some of the problems in ED are because of issues with access to urgent outpatient appointments. So it's not an emergency problem, it's not a GP problem, it's a process problem. And that especially in the time of financial hardship, we really need to kind of up the stakes on our efficiencies of the processes that we've already got, and not necessarily think about reinventing the wheel, I think.
Yes.
Our doctors do on-call and that includes the paediatrics and new ones. So one of the things that they can do is actually prevent people turning up at ED. It might be a patient that regularly, they've got the history, they have access into our server, they can pull up the database, they've got the information there. So a lot of patients can actually get medical advice that can prevent them turning up to emergency, but under the system of the after-hours incentive, that is actually not acknowledged at all in the
And I just wonder, if you spend a lot of the time defining primary type, I'm just not the question I've got is that a useful recommendation? When in fact you're not going to be able to audit some of these results. You could be providing that service, but because there's no patient registration in general practice, you haven't got a clue the effectiveness of that service. You could have people just going to another general practice, ending up in ED, you're providing all that service and going to ED anyway, but because there's no patient registration, you actually cannot audit the performance of general practice in that way.
But they can come and see us the next day. That it can actually be delayed, that it can wait until...
Yeah, you don't know. You don't know. You bring all that effort to excellent services, but you actually don't know whether you're having an influence on hospital demand.
Or if they're coming in to see the GP the next day, that is preventing that patient actually arriving at the emergency department.
So that's one measure. But I mean, what about patient registration? I mean, we run away from it. Every time we talk about it, and it seems to be the most logical thing we should be doing in Australia, is that patient should register with their GP. What do you think, Jim?
I agree.
I think registration has all sorts of advantages for measuring population health type initiatives. The key things are that there is choice and that there is an easy process to change your registration. And to have choice, there has to be a relative oversupply.
Just Mayor Draper said the health issue sector in the consumer organisation in Victoria.
So just picking up on that last dot point, which is actually sort of filling in the consumer experience side, and a number of all of the Medicare locals have undertaken consumer consultations as part of the section after hours. And in talking to Chris Carr, there might have been an attempt to pool the information from all those consultations but it will be quite useful to actually see what's come out of all those community consultations. And my understanding from talking to one of the people who was involved was that some of the issues that came out was that kind of what happened in hours was a critical factor in terms of what happened out of hours. And that secondly, there was a question of confidence. A lot of people had confidence in hospitals. There's certain kinds of things that they didn't have the same confidence in general practice for. So in a sense, I think it comes back to what Mary was saying. There's a whole lot of systems issues there, and by just looking after hours, we miss some of those.
Christine, do you view this? Given you manage an adult service as well as children's service?
Well, I think it's right that there is I think there is an issue of people having confidence. And I was just sort of thinking that it's partly what we see on television, isn't it? With all these ED programs and things, where people come in, get fixed up, come in really sick, get fixed up and go out, and there's a wonderful story. So whereas,
And they're prepared to wait for hours.
yeah, they do. But I think there is a confidence that a big hospital with lots of specialists and all this sort of business around, which is not entirely true, but that's the idea that people have, that it's a confidence thing.
If only they knew. If only
Yeah, people in the middle of the night, it's pretty mean, but yeah.
I've come to
I think it is.
yes.
Yes, I was initially going to comment on the comment about why do the Category 5s not go to general practice, and I'd just like to say I think general practitioners spend a lot of their time seeing patients that would be classified as
On a ratio of 20 to 1, as we heard earlier.
Absolutely, it's just what we do a lot of the time.
So the lead is actually relatively small, if it is a legal goal.
Imagine so, yeah. The other thing I was going to say, just with the registration, is I think the figures are something like 80% of people can nominate a GP and 90% nominate a regular general practice. So most people have a regular general practice. They may not be officially registered, but it's almost, it's a de facto registration that's happening already.
Did you want to say something?
Yes, just to go back to your philosophical question, what is it we're trying to solve here? And I don't know whether your study looked at, I would consider about costs. I would consider about the cost of ED separation as opposed to GP separation. And did you collect any data or look at that issue at all?
So that's the driver behind the study rather than what we looked at in the study.
No, we just looked at the VE data.
But one assumes that the Department of Health keeping the money because they're concerned about the cost of ED presentations. No?
That's not why we got here.
I'm going to write the hand of Jesus here, by the way.
Answer, by the way.
Yeah, okay.
But
We're listening.
personally, I wanted to challenge, like you said, what's the problem? Like, why are we focusing on after hours when it's a 24/7 problem? So, and I think I wanted to challenge that assumption that it was all about after hours, when in actual fact, maybe if GP practices were open from 10 to 9, we wouldn't have this problem.
Yeah. I think we have successfully, you'll be watching data there from that first presentation, but on the second one, you got that information. It is not an after hours problem specific. Very good, you wanted to say something.
There's a couple of things. No doubt ED care is expensive care, and that's an issue when you have a group of patients who can be equally managed elsewhere. And there is a growing phenomenon of the appropriateness of investigation and diagnostics. The phenomenon of the big white building on the hill is something at least that we personally have experienced at the Austin and the Mercy. I think if you build it and it's seen as a centre of excellence, then people do come, and increasingly people come with a request to see a specific specialist, and I think fundamentally there is an issue of, I suppose, confidence or education in the community about, rather than seeing a general practitioner, they come and ask for the gastroenterologist or the paediatrician, and
the CPG right too.
Yeah, so I think there's an issue there as well.
Thanks. Christine,
I was just going to say, I mean, it seems to me the problem is that we have a fixed number of hospitals. They don't grow particularly in number, and yet there's been a relentless growth in ED presentations over the years. So this fixed number is struggling to deal with this growth, whereas there, I assume, but maybe I'm wrong, there are more and more GPs out there in the community. So one of the problems is that is that I think the fixed number of hospitals are having trouble, are being challenged by the relentless growth in ED presentations year in, year out. We do all sorts of tricks to try and manage that.
But when you ask ED physicians, they say 4 to 5 aren't a problem. We should maintain
Yeah,
that.
but that's what they. Yeah, but at the end of the day, that's what they say. Yes, I do hear that. But at the end of the day, we're providing a health system in Victoria, and it's just making sure we can all manage a reasonable volume and provide the best possible care.
Actually, the same. This is something to do with
Arlene Wake from Western Health. I just wondered if there was anything or anything you found about diversion when there was a primary care provider co-located with the emergency.
Hold the thought. We're going to come to that in a moment in the presentation. We actually have an answer for you.